Okay, my name is Dr. George Hornby, and I was asked to present about high intensity stepping training and clinical evidence and recommendations. So, we use research to guide rehabilitation practice. There are specific rules or principles that have been formulated to help guide our treatment sessions, and they're based in the field of motor control, mechanisms, understanding neuroplasticity, and exercise science and physiology. And so, this paper from 2008 was published by Klein and Jones, talks about these specific principles, and there are really a few that we can really harness in our clinical practice: and specificity, repetition, and intensity. And the talk today was going to focus on primarily intensity. Typical definitions of intensity used in rehab have varied substantially over the years. For example, Carol Winstein, when talking in her methods paper about constraint-induced movement therapy, said that intensity was the amount of time focused on each training procedure. That's time, and that's not actually how hard someone's working. Stephen Page did the modified constraint-induced therapy, and that was intensity. It was operationally divided in terms of number of hours, also time. Stefan Hesse did a study of high versus low intensity. Intensity, in his case, he said 2 sessions a week, and high intensity was 4 sessions a week. That's actually frequency throughout the week rather than intensity. We have no idea of how hard someone's working. And then Andy Berman talked at a CSM presentation about the leaps, about intensities and number of steps, but that's amount of practice. All these don't really capture intensity. Intensity from the field of exercise physiology is the rate of work performed, or power or workload, or work divided by time. And you change intensity by increasing the speed or increasing the weight carried or the incline. Different levels of intensity have been defined by thresholds of cardiovascular workload, primarily by heart rate. And so what you're seeing here in black is the ACSM guidelines from 2010 and the Australian guidelines from 2010 about different thresholds of intensity from low, moderate, vigorous, and high. And those last 2, vigorous and high, have been the higher intensity groups. Those have since changed over the years. In 2017 and 14, they've adjusted them so that the new percentage of heart rate maximum thresholds for different intensity levels are provided. So increasing power or workload will increase the cardiovascular demands because the muscles are working harder, and you need that blood to be oxygenated to flow to those working muscles. In cases where the heart rate maximum may not be as accurate, particularly in patients with disability or with medications, we use the RPE chart. When we're going for high intensity, we're going for the vigorous to high levels, or an RPE between 15 to 18. So the recommendations of high intensity to able-bodied individuals or stroke participants are published previously, and really 30 minutes of modern intensity exercise, about 60 to 75% of age predicted max, for at least 5 days a week, or at least 20 minutes of vigorous exercise, getting up above 75% predicted heart rate max. And we use the principles of FIT, the frequency, intensity, time, and type. How frequent are you doing it? How intense? How long? And what type of activity? And type we haven't identified, but sustained rhythmic volitional contractions that are aerobic in nature. If you look at the effects of higher intensity on healthy locomotor performance, these are running studies, college-age individuals doing running studies. One group ran at lower intensities, one group ran at higher intensities, but they kept the mileage the same, and the group that had the higher intensity tended to improve better. When we look at neurological populations, recommendations from ACSM and meta-analyses indicate that higher intensity exercise improves to improve selected locomotor outcomes. Early studies applying cardiac rehab to patients with stroke, done by Richard Mako and colleagues, used about 60 to 70% of heart rate reserve, and they got good outcomes, primarily in the 6-minute walk. Other individuals tried to go at faster speeds, and they've got some variable changes in gait speed or gait efficiency or in daily stepping. And then more recent studies have looked at high versus low intensity in stroke and spinal cord injury. And really 70 to 80% heart rate reserve was much better than the lower intensity of 30 to 40% heart rate reserve, which is about 50 to 65% of heart rate max. And we see improved peak metabolic capacity and efficiency as well as functional measures of change. So if you're thinking what this looks like, you take a really impaired individual who can barely ambulate, and you're just letting him go and pushing him. There's a pulse oximeter on his forehead, and he's doing these very difficult tasks. Now, he's moving slow, but his Berg, for example, is 5. So he's very impaired and really struggling quite a bit. His heart rate is escalated. It's really important to measure how hard these individuals are actually working when you're doing these tasks. And here's a higher level individual doing the same paradigm that we had in the lower individual, except this individual has less deficits and can do more. So he is dragging us down the hallway. Again, the pulse oximeter is on his forehead. First shot at running, a higher level individual with stroke, and the last shot. So the intensities are the same in these two individuals. Their level of disability is different, and hence the paradigms look very different, but it is the same intensity. Intensity becomes really important in older studies, and particularly when we think about robotic devices. Some of the problems with robotic devices is that individuals tend to relax in the device. So if you look at robotic assisted training from the Locomat, Hornby 2008 and Heiler 2009, also a couple spinal cord studies by Philfote and Labriere, they showed that walking training in the Locomat was inferior statistically to other interventions that didn't put them in the robot. So conventional training or higher intensity treadmill training, walking over ground, or strength training. And what you're seeing here on the right is from the Hornby trial, and how the reduced gains with robotic assisted training. This is a percentage of the change at post 4 weeks of training in 6 months versus therapist assisted. And the rationale was that by looking at metabolic costs of walking during the Locomat versus outside the Locomat, and looking at muscle activity patterns, look at kinematics, heart rates and metabolic costs reduce substantially when you're in the robot, right? That was a major flaw and probably contributed to the differential walking gains in these other studies. So again, when we think about cardiovascular responses and how they are different, well, those are different because the muscular activity is different, right? Because the muscles aren't working as hard. And the muscles aren't working as hard because the nervous system is not driving the system as hard, right? So when we think about neuroplasticity, we really want the nervous system to drive harder and to form synaptic changes that will strengthen synaptic connectivity in brain pathways that we utilize. So the higher neural command will drive the higher muscular command, which will then drive the higher cardiovascular responses. That's why we want this intensity. And that unfortunately gets sacrificed in robotic devices. When we think about clinical practice guidelines, more recently, the recommendations were you should do high intensity training, focus on walking. Why? Because it's task specific and it's higher intensity. When you think about other strategies like strength training, circuit training, cycling, all of these other ones at higher intensity, the intensity is good, but it's not task specific. So you don't get as good of outcomes. And then when you think about robotic training or just therapist assisted training, the recommendation was should not. These are task specific, but they're really low intensity, and that's why the outcomes may be different. And we focus on robotics, if we look at intact individuals, these are able-bodied individuals, and these are devices that are not necessarily robotics, but assisted some tasks. So Roger Cram, Art Quo, Ginger Gottschall, Max Donlin, all did some kind of elastic devices, and they utilized those to pull on the limbs in different ways and found that people relax their muscle activity when they're being assisted on a treadmill. Myoelectric control devices by Daniel Ferris and Keith Gordon, when you reduce certain activity for plantar flexion, you reduce metabolic costs. Like you automatically do it. And if you look at other mechanical devices, Donninger and Selinger recent studies, like you can perturb robotic devices in different ways, but the underlying theme is that robotic devices continue to actually elicit changes that minimize oxygen costs. In particular, the Donald and Selinger group thought that energy optimization and minimization was a rule. You automatically want to reduce the work of walking when you can, not an actual outcome. So these devices help, and by helping, they automatically reduce costs. When you look at patient populations and you look at robotic assisted training, we mentioned the Israel and other studies of metabolic cost during Locomat. But more recently, even when you reduce the guidance and reduce the force that the robot applies, individuals who are very impaired post-stroke or ambulatory, they continue to relax. Robotic assisted stepping may provide more practice, but reduced intensity tends to minimize those gains, which is why you see those negative results. So the current evidence for robotic devices is sparse, and it's actually not clear that they even should work based on the data that we have. And so the other groups are going to try to convince you that they are beneficial, and we'll hear from them now.
Okay, good afternoon, everyone. I'm very happy to be with you all today. For my portion of this talk, my goal is to give an overview of cardiac propulsion deficits after stroke and the relationship to how fast and far people can walk. I'll then introduce you to a new class of wearable robot made from soft functional textiles. We call these soft robotic exosuits. And I'll share with you how we are using this new technology to help people post-stroke walk faster and farther during gait training and ultimately achieve better outcomes. All right, and to dive right in, shown here is a single cycle of walking broken down into its 3 parts. For anyone walking on 2 legs, this basic underlying pattern of body weight support, propulsion, and limb advancements there. The challenge is that disease or injury to the neuromotor system can disrupt the execution of one or more of these subtasks or the transition across the subtasks. And when this happens, physiological walking, that is typical, healthy walking behavior, is not achievable without some form of intervention. And the focus of my talk today is on the middle propulsion subtask. When I say propulsion, I just mean a means of creating forces that can lead to movement. And if we take a moment to think about propulsion outside of the domain of walking, our lives really rely on technologies that we have created to help with the act of propulsion. Technologies that do a large part of the work required to create the forces needed to move us around our world. Before COVID-19 turned our world upside down, many of us would have routinely taken advantage of jet propulsion technology. And if you drive to work every day, you rely on car propulsion technology. And if you are a bike commuter, your bicycle acts to augment your natural human propulsion abilities, allowing you to travel faster and farther than you would be able to on your own. And for individuals with neuromotor impairments, we have built impressive propulsion technologies that compensate for lost propulsion function. And these technologies can range from a wheelchair, which you saw to the back of this video earlier on, to a powered exoskeleton that can fully support an individual's body weight and help them walk again. But of course, normally we don't need technologies for propulsion. We are neuromechanical systems that are built for propulsion. With every step that we take, the neuromotor system moves our body by sequentially activating different groups of muscles in a highly coordinated way, causing our limbs to push off the ground, creating the ground reaction forces that move us about our world. Now, fundamental to physiological propulsion is the ability to activate the plantar flexor muscles of the trailing limb with the right timing and magnitude as the body arcs over and in front of the leg. Let me explain. Bipedal walking consists of alternating periods of single limb support and double limb support. During single limb support, the body's center of mass arcs over the stance limb like an inverted pendulum. And this allows us to leverage gravity to perform much of the work of walking. However, during the double support phase, the body center mass is directed downward and forward, and something has to happen to redirect it upwards and forwards and into the next gait cycle. Now, we know when that leading limb strikes the ground, it stops the body from continuing toward the ground, and thus it acts to redirect the center mass up. But the leading limb also provides a decelerating force on that center of mass, and that has to be accounted for. And in healthy walking, the plantar flexor muscles of the trailing limb are the primary actors that restore the forward acceleration of the body, that is, that restore propulsion. Unfortunately, in people with post-stroke hemiparesis, the parietic plantar flexors, shown here in light gray relative to the non-parietic plantar flexors, are markedly weaker. The parietic plantar flexors generate 40% less total force than the non-parietic plantar flexors. Moreover, the neural drive to the parietic plantar flexors is reduced. So not only do people post-stroke not have as much force generating capability, but they have a reduced ability to access the force generating capability that they have. As a consequence, if we plot the anterior-posterior grand reaction forces generated by the paretic in blue and non-paretic limb in red, we see a substantial asymmetry across the limbs, with less total anteriorly directed grand reaction force by the paretic limb compared to the non-paretic limb, with a propulsion asymmetry across the limbs. And impaired paretic propulsion has important biomechanical and functional consequences. Propulsion impairment is associated with a higher cost of transport, slower walking speeds, and a reduced ability to walk far distances. And we can spend a lot of time on each of these, but for the sake of time, let's focus on walking distance. Here I'm showing you the relationship between paretic propulsion on the x-axis and the total distance a person is able to walk during the 6-minute walk test on the y-axis. And you can see that individuals with low propulsion walk low distances on the 6-minute walk test, with individuals classified by the 6-minute walk test as home ambulators, people who walk under 2,500 steps per day in the real world, producing less than a third of the propulsion that community ambulators, people who walk over 7,500 steps per day, less than a third of the propulsion produced by that subgroup. And this is important clinically because the 6-minute walk test, again, is among the best predictors of community walking activity after stroke, with people who walk far distances, shown here on the right of the x-axis, walking more steps per day in the real world than individuals who walk short distances during a 6-minute walk test. And this is a variable here on the y-axis that we measure with a step activity monitor or something like a Fitbit. We put it on an individual, we send them out to the real world for up to 7 days, and then we average how many steps that they take over those 7 days. So this is a measure of real world participation. Now, one would think that given the importance of plantar flexor function to the physiological propulsion that's needed for a fast, stable, and efficient gait, that there would be a number of interventions available to restore plantar flexor control during walking. But if today you walk into any of the major rehab clinics or centers across the country, you're going to see that actually few clinical interventions are designed specifically to restore plantar flexion during walking and retrain paretic propulsion. But perhaps more importantly, not only do we lack effective propulsion interventions, some of our standard interventions actually impede propulsion ability. For example, among the most common interventions used after stroke is the ankle foot orthosis. The AFO is a crucial piece of assistive technology that can provide stability during the stance phase of walking, as well as help with ground clearance during the swing phase. But because an AFO constrains the movement of the ankle, an AFO is detrimental to propulsion. That is because AFOs hold the foot at about 90 degrees. As soon as an AFO is prescribed, the recovery of plantar flexion ability of physiological propulsion is unlikely. Now, I'm not saying avoid AFOs. AFOs are a crucial tool for facilitating safe and independent walking in people with post-stroke hemiparesis. What I am saying, though, is that our goals need to go beyond safe and independent walking. To maximize long-term gait outcomes, we need interventions that provide the stability and ground clearance support of AFOs, but not at the expense of propulsion. If our patients can't propel normally, the resulting compensations will reduce speed, increase the cost of walking, and constrain real-world physical activity. And this leads to our team's central hypothesis that in people with post-stroke hemiparesis, soft robotic exosuits that operate in parallel with the impaired paretic muscles can functionally restore the plantar flexor function crucial for propulsion, and by extension, reduce the energy cost of walking, increase walking speed and distance, increase physical activity, and ultimately improve the quality of life of our patients post-stroke. Now, over the last 6 years, our team has progressed from the development and validation of the foundational exosuit technology to developing a novel gait training program designed to leverage unique properties of the exosuit technology to target deficits in paretic propulsion. And our current work focuses on the progressive staging of pilot studies before eventually launching into a multi-center trial. Now, without getting into the details, our work began with lab-based platforms, transitioning to functional prototypes, and currently we're using FDA-approved clinical devices. For the purposes of this talk, I'm going to skip over the technology development shown here, and instead overview our early studies focused on biomechanical validation and therapeutic feasibility, labeled here as stage 1, consideration of concept, and stage 2, development of concept. And we are still quite early in the evidence generation pathway here. Currently, we're in the middle of a small, very small randomized control trial focused on evaluating efficacy and effect sizes. Now, although I'm presenting these stages in a linear fashion, we consider the process to be quite iterative, both within and across the different stages. Now, our first studies examined the immediate acute biomechanical effects of an exosuit on post-stroke walking. Our primary interest was on treatment fidelity. Does our provision of external forces to the paretic limb through a soft human-machine interface produce the biomechanical effects that we expect? And this included studying the effects of not just the provision of stance phase plantar flexion, shown on the right here, but also providing active dorsiflexion assistance during swing phase to address the deficits in ground clearance that we know our patients also have. And when powering on the exosuit's dorsiflexor actuator, we did see improvements in dorsiflexion angle during swing phase. The unpowered condition here, shown in gray, we have a negative 2 degrees of dorsiflexion during swing. That is 2 degrees of plantar flexion, drop foot during swing phase. And when we power on the exosuit, here in red, we see about a 4 degrees average dorsiflexion during swing phase. So the exosuit, when it applies dorsiflexion assistance, can provide that ground clearance support that our patients need. Now, moving on to our plantar flexion related outcomes, we saw about a 10% increase in propulsion output from the paretic limb across individuals. And this led to an average 20% reduction in propulsion asymmetry, shown here on the y-axis, across the paretic and non-paretic limbs. So that propulsion asymmetry I showed you earlier is reduced when you power on the exosuit. Now, earlier in the talk, I explained that impaired paretic propulsion is linked to a high energy cost of walking. And in support or inconsistent with that framework, with the device powered on, people post-stroke experienced an average 10% reduction in the cost of transport. And when considering this reduction relative to the cost of transport of healthy individuals, the device produced about a third, a 30% reduction in the metabolic burden of post-stroke hemiparesis. A zero value shown here on the y-axis represents the average cost of transport among healthy older adults. So with the exosuit powered on, that metabolic burden due to post-stroke hemiparesis is reduced by about 30%. And in further support of the relationship between propulsion and the energy cost of walking, we saw that improvements in walking economy were strongly linked to improvements in propulsion symmetry in the small sample of people post-stroke. Now, we have other studies examining acute effects of exosuit walking on neuromotor control. Shown here is for one individual, decoupling of a merged muscle module. We also are looking at using functional near-infrared spectroscopy neuroimaging to measure cortical activation during exosuit augmented walking. We're interested in cognitive load during the use of the exosuit. But for the interest of time, I'm going to transition to speaking about our early studies on the therapeutic effects of the exosuit technology. I'm happy to take any questions that people may have later on. So here, our approach was to apply exosuits that could enhance gait to gait training, with the goal of producing long-standing benefits that persist even when you take away the device. And one of the first questions that we asked when making that transition from technology development to clinical focus was, can people post-stroke utilize the assistance to improve their walking speed and distance? These are key clinical outcomes that are highly associated with health and everyday walking activity in people post-stroke. And in a recent paper published in IEEE's Open Journal of Engineering and Medicine and Biology, we reported the results of a small initial study with 5 people post-stroke, where we observed clinically meaningful improvements in both walking speed and distance outcomes. Now, motivated by this evidence for soft robotic exosuits being able to both increase propulsion and increase long-distance walking speeds, we have an ongoing early-staged RCT testing a standardized gait program that we refer to as the Robotic Exosuit Augmented Locomotion, or the REAL gait training program. Happy to answer questions and share the details later on, but briefly, REAL gait training leverages unique aspects of the exosuit technology while drawing on contemporary principles of neuroplasticity and motor learning to provide high-intensity, task-specific, and progressive gait training, with special focus on cue-directed training of gait parameters associated with the propulsive force produced by the predic limb. Taking advantage of the portability of the exosuit technology, we apply real training in the lab-based setting where we can make precise measurements. We take it out of the lab into a clinical environment and eventually out into the community as well. Now, another aspect of the exosuit technology, beyond its portability, that real training takes advantage of, is the fact that because it's so lightweight, with the majority of components worn on the limbs made from soft textiles, it has the ability to quickly get out of the way of the user by simply turning off the power. It has a transparent mode. Because of this property, we can use a training mode that we call intermittent assistance, where we interleave periods of walking with assistance with periods of walking without assistance. And this approach allows us to leverage post-adaptation periods of walking without the exosuit assistance, as you can see here, to maximize motor learning. Now, I can't share the data from our ongoing RCT, but we recently published a single subject report for a very interesting case study that you may be interested in. So this person was one of our key participants during the development phase of the study, coming to our lab over 40 times in a 2-year period to test different versions of the device. And during this time period, we did not train him at all. We just put the device on and measured how he responded. And over those 44 visits, we took 10-meter walk test speeds at random visits. And they're represented here by these 4 different days, time since stroke, here on the x-axis. And you can see across these 4 days, he has a pretty stable walking speed of about 0.96 meters per second. And then we took him and invited him to participate in 5 visits of real gait training. So highly intensive, progressive, and standardized gait training. We did a pre-evaluation and a post-evaluation. You're looking at comfortable walking speed shown here in blue, max walking speed shown here in orange, and the 6-minute walk test shown here in gray. And for each of these outcomes, speed and distance, you can see quite a large change, larger than the minimal clinically important difference for each of these outcomes. More excitingly was the therapeutic change in his propulsion biomechanics, with substantial gains in the anterior ground reaction force from pre to post-eval at a comfortable speed, at a maximum speed. And if you look at key characteristics like the peak propulsion and plantar flexor power, not shown on the slide, they're also changing in the positive direction. And of course, as I mentioned earlier, this work is still in the very early phases of evidence generation. Our focus is still on defining and developing the key elements for exosuit augmented gait training. And I'm looking forward to sharing with you the results of this scientific journey in the coming months and years. And so with that, I want to make sure to highlight the major team effort that has gone into this work across our teams at BU, Harvard, and Spalding, as well as our work with PIs across the country in industry-sponsored trials, including Dr. Esquinazzi at Moss Rehab, Dr. Arun Jeriman over at Ability Lab, Dr. Karen Nolan at Kessler Rehab Hospital, Dr. Gerard Francisco over at Tier Memorial Hermann, fantastic community of individuals working with this technology. Thank you all.
Hi, my name is Kristen Hull, and I'm a physical therapist at the Shirley Ryan Ability Lab. And we're talking today about the clinical evidence using emerging robotic modalities to promote high-intensity gait training. And I want to take the time to thank Dr. Arun Jayaraman for the opportunity to speak about some of the data from his lab on one of the case series today. I have nothing to disclose related to this presentation. And as Dr. Hornby reviewed previously, there are 3 key active ingredients to successful high-intensity gait training. The Locomotor CPG recommends focusing on interventions that are specific to walking, intensive enough for adequate aerobic challenge, and providing an adequate repetition. Robotic technologies can help facilitate this through appropriate clinical decision-making and application, and we'll go through that today. Robotic technologies, what do I mean? What devices? Well, these are the ones that we'll talk about today. These are overground exoskeletons that are single joint or multi-joint. They may be hard materials or soft textiles. They are approved by the FDA for clinical and/or personal use, And I'm not talking about that Locomotor or the GEO system that are fixated to the treadmill. In terms of what evidence for those is out there for the use of those technologies that are in that green text box there, that's more of those small randomized controlled trials at this point, or larger case series are available in the published literature. So it's a little bit more limited, but it's starting to kind of emerge. As a clinician is choosing to incorporate technology into a patient's plan of care, it's really important to consider the deficits and impairments, and those are kind of listed here on the left. And consider how you're going to pair that with the technology's capabilities. This part of the decision-making is really critical because a random or mispaired technology is going to be frustrating, ineffective, and really potentially unsafe. That first one that I listed there is biomechanical subcomponents of gait. And this is something that you can use not only to look at someone's gait quality and think about, are they being successful with their walking, but also break down, how would I then use a technology in these parts to successfully improve their walking or target the deficits? So this involves 4 different steps. The first one is stance control. Are they able to accept their weight without limb collapse or trunk collapse? The next one is balance. Are they having any difficulty with sagittal or frontal plane stability? For limb advancement, are they able to get a step through and get their step that's past the other foot? And then the last one here is propulsion, which is the ability of the to move the body forward separate from limb swing. So we'll use this today as we kind of talk about those case examples. Our first case example is a 63-year-old woman who presents to outpatient physical therapy with a 25-year history of relapsing and remitting MS. She also presents surprisingly with an acute on chronic low back pain and a relevant left lateral shift. And she wants to try technology to improve her endurance, with this caveat that she's had to use her manual chair a lot more because she has such significant back pain. And just to let you know, she historically is from out of state and historically has seen a PT 1 time a week to preserve her insurance benefits, and kind of throw that up on end and say, I'll see you 3 times a week for 3 weeks. So a lot more intensive. And these sessions are 45 minutes each. So if we look here at the video, this is her baseline walk. You can see she's using bilateral hiking poles, and we look at her gait components. She's having deficits, certainly with balance, and because of her, bilateral hiking pole use. You can see her left lateral shift in her trunk. In terms of propulsion, it's definitely an issue, as well as limb advancement. I have saved you the fear of when she catches her toe here and she nearly goes down. So definitely limb advancement of an issue. In terms of her baseline walking speed, it is 0.58 and 0.8 meters per second. We did this with a straight cane because this is the device that she usually would use around her house. So I chose to use the Indigo with Therapy Plus software because this was something that would target both joints as well as be able to customize assistance as she needed it through swing phase. So we had a gradual reduction in the amount of gravity reduction for her to better tolerate the device, and then also customize how much the device was helping her through swing phase as she improved through the sessions, as well as within each session would get more fatigued and maybe need a little bit more help. As the video loops here, you can see she's doing some training over ground, some training on the treadmill, maybe at a little slower speed here. And then you can see the treadmill is going faster because she's gotten better and she's able to actually then do intervals on the treadmill. So how did we achieve those active ingredients with this type of training? Was it specific? Well, certainly she's doing overground to treadmill, and treadmill training then to overground. Actually, then we would transition outside the device to try and carry over some of those kinematic things we were working on. For intensity, we rated this using the Borg RPE scale, and she would rate it usually between 12 and 15, which is below what you would be targeting for really high intensity training, or just on the very low end of it. And that's probably appropriate given her diagnosis. In terms of repetition, she would, in this 45-minute session, she would get 23 minutes of walking time in actually walking in the device, 1 seated rest break in these 8 training sessions, and average among those sessions was 1,190 steps. Fairly good for this woman who's not able to walk much and is using a wheelchair for most of her mobility. So certainly getting a nice amount of steps in. So what do we think about our outcomes here? She has a 0.17 meter per second improvement in her self-selected walking velocity and 0.12 meters per second improvement in her fast velocity. And really, as I think back to this case, the technology really allowed achievement of the active ingredients, primarily with increased repetition and dosage that would have been prohibited if she hadn't used the technology because of her back pain. She had significantly improved tolerance because the device actually did a shift correction for her and decreased her back pain substantially. And if she didn't have the technology, we would have been limited to 20 to 40 feet bouts at a very slow speed. And I think the other piece of this is to take away the chronic and progressive conditions and how we think about structuring their plan of care. It's easy to say, let's try to stretch out your visits to get you kind of throughout the year. But I think then, is it more effective to see these patients for shorter lengths of stay that are more intensive on touch points? And perhaps this is a demonstration of that. Our second here is actually the case series that comes from Dr. Arun Jayaraman's lab. And this involves 5 subjects who actually were pretty high functioning level post-stroke. Their mean age was 46.5 years and about 2.7 years post-stroke. In terms of functionally, 3 people were using an AFO or some type of ankle brace. Only 1 subject was using a straight cane in the community at the time of training. And this is a subject here on the right on the video, his baseline walking. If we look at the group as a whole, biomechanically, 1 individual had deficits in stance control, while everyone, we could say, had deficits in propulsion, and others had deficits in limb advancement to minor degrees and minor balance compensations, often occurring at the trunk level. Their baseline outcome measures pointed to their higher level of functioning, 0.97 meters per second on their self-selected velocity and a 19 out of 30 on the FGA. Puts them at a higher fall risk on dynamic balance, but still fairly high functioning. And I should mention here that even if they were an AFO in the community, they were tested with these outcomes without their AFO or their brace. So given their biomechanical components, we would use the Rewalk Restore here. So this is targeting individuals with propulsion deficits and primarily deficits that we felt like were targeted towards their ankle. So we used Rewalk Restore, which is, you can see here on the left, is an ankle plantar flexion assist device in terminal stance, and then assists through swing phase with active dorsiflexion through the use of pulleys. There was an 18-session training study that had intervals of walking training that was specific to their daily walking speed. And not only was it speed-based, but it also was focused on targets of improving their kinematics. And so they could move on to different parts of the study once they showed that they had satisfactory walking kinematics. So did this study satisfy those active ingredient principles? Did we show specificity? Certainly. We did interval bouts of treadmill progressing to overground training. Was it intensive? Well, I'll show you data from 1 subject, actually the subject you just saw in the video there. He has spent an average of 24 minutes in the 70 to 85% heart rate zone on average amongst his sessions. And when you look at the raw data of total heart rate time, 61% of his total session was above 71% of heart rate max. And his sessions were about 3,000 to 3,500 steps per session in those total 30 minutes of walking. I would say that's intensive. And really, if you take this away, it's also very feasible to carry this out in a clinical setting. Can you get 30 minutes of walking training in? By all means. Is it feasible to put this device on in a short amount of time? Yes, it is. So this is something that's definitely something that can be carried out in the clinical setting, in an outpatient setting for your higher level patients. For the clinical outcomes we talked about earlier, this is the percentage improvement. From a statistical perspective, every outcome measure showed improvement statistically, except for fast velocity. And from the raw numbers perspective, self-selected walking velocity improved by 0.22. Dynamic balance on the FGA improved by 5 points, and 6-minute walk test improved by about 71 meters pre to post. Again, no bracing. Again, this is not just a study that we were focusing on speed and number of steps, but also focusing on gait quality and weaving that in. And so we were interested in seeing how did their walking change from a metrics standpoint. And so we used Xsense to look at their gait quality. And this is, interestingly, the changes that we saw occurred at the hip and the knee, which is an interesting thing. It didn't occur where the device was acting. So we saw improvements on a statistical significance for improvements in amount of hip flexion extension range on both bilateral hips, and improvement in symmetry of the hips and the knees pre to post. And then there was also a significant improvement on the affected side of knee flexion extension range. So this is a really brief kind of presentation, and I only showed a case example and a case series, but I really hope this presentation can give you an idea how well-supported active ingredients of high-intensity gait training can be integrated when you utilize these new emerging technologies. And I think for the first case in particular, it was a bit of a secondary gain that the technology afforded us with improved tolerance because of her pain and limited walking ability. So if I can reflect, I would say this is something I would actually add to my diagnostic list of considerations of deficits and impairments in considering if technology would actually help in the future. And I think the data in our case series shows that in addition to focusing on these active ingredient principles, focusing on gait quality as well can result in improved kinematics following the interventions. And so don't be afraid to be that critical thinking mixologist. Go for it. If you have any questions, please reach out to me with my email listed here. I've also included Dr. Arun Jayaraman's contact if you have any additional questions for him regarding clinical research studies using technology. I'm sure he'd be more than happy to engage. Thank you so much.
My name is Andrew Packle, and I'm going to be talking about individualized therapeutic targets for locomotor training. So hopefully to this point, you've got the message that intensity is important. And that's the number one thing. If you're not sure what to do with your patients, get them working harder. And intensity is number one. We're going to go with that. However, we know that there's also other things that are important. So you've seen this list of principles of neuroplasticity from Klein and Jones. We've been focusing heavily on this intensity piece. We've talked a fair amount about this repetition piece. The thing I want to talk a little bit more specifically about here is specificity. So what do we mean by specificity? How do we think about specificity? So at its most basic level, when we think about specificity, we recognize that in order to improve somebody's walking ability, we need to have them practice walking. So that's a basic application of specificity. But can we think a little bit more deeply? Can we be more specific about specificity? So how do we need to improve somebody's walking ability? If we can think about that question, then that may direct us towards how I should help them practice their walking ability. So we're going to see what that might look like. In order to do this, we're going to use what we identify as walking deficits. So we're going to think about how our patient presents and what their deficits related to walking may be. And we want to think about this in a way that's functionally meaningful, that is systematic, objective, and measurable. We need to be able to agree upon what we mean by these things. And the way in which we think about these walking deficits, very importantly, needs to help us inform our treatment decisions. So we identify these as aspects of walking. These are going to look similar, but not identical to what Kristen described as the biomechanical subcomponents of gait. So I think it's important to realize that we, as a field of rehabilitation and of walking, people who are involved with walking, we don't have a uniform, agreed way to think about these deficits yet. But we identify them as aspects of walking. And so the ones that we particularly focus upon are knee stance stability, the ability to maintain the trunk upright, limb advancement, and dynamic balance. So similar to that list that Kristen showed you, but a little bit different. We've talked a fair amount about paretic propulsion. And in this model that we use, we kind of think about that paretic propulsion as a piece of limb advancement. It helps with limb advancement. It helps with moving the body forward. Again, we need to come together as a field and to agree upon a uniform way to describe these. But for this purposes, we're going to talk about these four aspects of walking. So how can the consideration of these different aspects of walking help us to direct our treatment strategies and help us to evaluate the effectiveness of our treatment? So it's very important, I think, as we're establishing our practice as clinicians, that we can, when we perform a treatment, we have awareness of how successful that particular treatment is that helps to improve our clinical reasoning. So I think an important piece of identifying these aspects of walking is it helps us to more closely identify how effective our treatments are. And we'll see that a little bit later. So how does this help us with this piece of specificity? So I can recognize that if my patient has a particular deficit in a particular aspect of walking, then, as I've said before, I need to facilitate practice walking. But now, having identified that particular aspect of walking, I'm going to focus my practice on that particular aspect of walking. And critically, I'm going to try to provide the appropriate level of challenge for that particular aspect of walking. We know that level of challenge is an essential piece in terms of motor control and motor learning and neuroplasticity. So we're going to make sure that we get the appropriate level of challenge for that particular aspect of walking. And then there's also other important parameters that we've been discussing. We need to make sure the patient has feedback regarding their performance in that particular aspect of walking. And that may be some intrinsic feedback from the task itself, or it may be extrinsic, supplied by myself or supplied another way externally. We need to make sure that our intensity is appropriate in our walking practice, and that dosage, that number of repetition, is also important. So let's look at a clinical example and what this might look like. So we're going to watch a video of a gentleman who is in inpatient rehabilitation about 3 weeks following a stroke. And the purpose of this video is just to give you an idea of what his walking ability looks like. You can see in the video, I've applied what we think of as compensations here. So he's using a solid rail to assist him with his walking. So that's an explicit compensation that we provided. I'm providing some physical assistance. So that's a piece of compensation that I've applied. He's got a brace on his lower leg, on his left leg, as you can see. That's compensation. I've got a piece of material to help his foot slide a little bit better. We call it a toe slider. That's a piece of compensation. So we recognize in this video that he's got some compensations. Importantly, when I'm assessing those particular aspects of walking that I discussed, we want to make that assessment without compensations for that particular aspect. So we've got a picture of this gentleman walking. Now, if we have a way to apply an objective way to evaluate those aspects of walking, it might look like this for this gentleman. So we're going to rate the severity of his deficits in those particular aspects of walking. And we're going to identify that his knee stance stability deficit score is 3 out of 4. So he has considerable deficit in knee stance stability. Note that the AFO may help to compensate for that in this video, but if we evaluate his knee stance stability, we're going to grade it a 3 out of 4, the deficit. His trunk upright is not bad, a 1 out of 4 deficit. Limb advancement, 3 out of 4, and dynamic balance, 3 out of 4. So this gentleman who has significant difficulty walking has multiple deficits in his aspects of walking. So how might that help us clinically moving forward in deciding how to perform walking training for this gentleman? So here's the question for clinical reasoning. I'd like to be able to challenge the aspect of walking that he needs to work on. And if I've identified that he needs to walk on a number of those different aspects, can I find a way to challenge every aspect of walking in the appropriate manner while still providing that appropriate feedback, intensity, and dosage? That's a tall order to be able to challenge all those things in the appropriate way at once. So instead, I'm going to prioritize a single aspect of walking that I want to challenge in a particular walking training trial. And I'm going to make sure that I'm providing the optimal level of challenge for that aspect of walking that I'm looking to target in a particular bout of walking. I'm going to make sure I'm still providing appropriate feedback, intensity, and dosage. And then I'm going to recognize explicitly that I may need to provide compensations for some of those other aspects of walking. I think it's going to be too much. And my clinical experience has led me to believe over the years, it's too much to be able to challenge every aspect of walking all at once in the most optimal way. So I'm going to focus on a particular aspect of walking, and I'm going to allow some compensations for other aspects of walking. So imagine for this gentleman that I've decided for this bout of walking training, I want to focus on the aspect of walking of limb advancement. So that means I'm going to look to provide walking practice with the appropriate level of challenge for limb advancement. I'm going to make sure he's aware when he's successful or not in his limb advancement. Again, that could be more intrinsic or extrinsic feedback he's receiving. I'm going to make sure he's got appropriate intensity and dosage. And again, I'm going to recognize that doing all those things may require some compensations or assistance for other aspects of walking. So the first thing we're going to do, we're going to watch that same video again, keeping in mind the goals for this particular bout of walking training and thinking about how well we're doing. So if we watch him walking, we can see he is working at limb advancement and he's got a particular level of challenge. Again, what's the appropriate level of challenge? I'm typically looking for a little bit of struggle. I don't want it to necessarily be perfect. I want him to be challenged by it, but I want him to largely be successful. So maybe he is getting an appropriate level of challenge for limb advancement in this training session right here. When I think about those other pieces, when I think about, is he getting enough intensity? Is he getting enough dosage or repetition? That's when I question if this is going to be an effective way to get him walking. Is he going to get enough intensity and dosage to be able to drive changes in his walking ability? So how else might we be able to do it? So we're going to see another video using a robotic device. The goal here is still to target limb advancement. So we still want him working at limb advancement with an appropriate level of challenge. So in this robotic device, if you watch that limb advancement, you can see sometimes he's struggling a little bit. Again, that's what I want to see. Importantly, this robotic device allows me to titrate, allows me to adjust the level of assistance the device is providing for that limb advancement. So I can tune it down until he's struggling a little bit, until he's being challenged for limb advancement, although I still want him to largely be successful. I would argue that he's going to be able to get more dosage, more repetition here. This intensity piece, he is working quite hard, and I can judge that by heart rate, and I want to be systematic about that. I can look at level of exertion and whether he's working hard to get this intensity piece. So if we think about those aspects of walking in that bout of walking practice, we can recognize that this device did provide some assistance for knee stability, some compensation for knee stability, although that's something I can sort of fine tune with the device or titrate also. The device provides full explicit assistance for the ability to maintain his trunk upright. So that's not something he has to worry about. The device is going to help him with that. Conversely, I could recognize that he's not working on the ability to hold his trunk upright within the device. Limb advancement is what the target of this treatment session is the ability to advance his limb when walking. So again, it's providing some assistance for that, but I'm able to titrate that level of assistance to get it right where I want it. And then dynamic balance. When I'm in back helping to guide the device, I am compensating for his dynamic balance. I'm not looking for him to be able to control his dynamic balance. So again, in this instance, if I was looking to work on dynamic balance, this device operated in this way may not be the best way to do it. So again, I've recognized that I can compensate for other aspects of walking while I'm really focusing on that limb advancement piece that I identified as my focus. So when we look at this clinical example, then we recognize that we can start to think in a wider sense of how these aspects of walking may help with our clinical reasoning and our selection of robotic devices. So in this chart on the left side, I've got some different robotic devices, as well as I've got manual body weight support down at the bottom to see how that might compare. And then I've got up at the top my different aspects of walking and the ability of the different devices to compensate for that piece. Often that's what we're looking for those devices to do. So this is sort of a work in progress. It's not meant to be definitive information, but this is showing how consideration of these aspects of walking can start to help us unpack what these different devices can do and how they fit into our walking training when we're looking to target a particular aspect of walking. So this is something we're actively working on fleshing out a little bit further. But hopefully you can see how identifying these particular aspects of walking can start to help us recognize what different devices may be able to do. So how does that fit into our bigger picture of therapy practice and walking training? So here's a model in terms of how we currently manage walking training. So we perform an examination, and then there's treatments, and then there's outcome. The examination typically is focused on impairments. We look at some observational gait analysis is the way we typically look at gait these days. And then maybe we consider the level of independence. That leads us to some type of walking practice training, which we're usually not great at specifying and describing and deciding about how we're going to perform that walking practice. And then we measure some outcomes that's not necessarily clearly identified how those are related to our walking practice as well. So this leaves us a lot of questions about how we choose our treatment and what our treatment looks like, questions about how our examination is related to our treatment, and then how that treatment is related to our outcomes. Now, when we consider those walking deficits that we identified, it changes the picture a little bit. So it adds this piece about proximal change in there, and we're going to see what that looks like. So now our examination for walking ability is really focused on identifying walking deficits. That's the primary piece we're going to look at when we're evaluating walking ability, is identifying these walking deficits. That leads us to a treatment to focus on particular aspects of walking deficits. When we're looking at measuring the proximal change, I've just performed a treatment that I'm hoping will change a particular aspect of walking. Now I can evaluate, did that treatment change that particular aspect of walking as I wanted it to? And then, of course, I'm also going to look at those larger outcomes and those outcome measures that we know are important to be able to measure across patients. So what this does is it gives us a better way to describe, define, decide upon the treatments that we're going to provide for walking ability. It takes those links between examination and treatment and solidifies them. We know that the examination is focused on the identification of walking deficits, and then the treatment is going to directly follow to target a particular aspect of walking in a particular session of treatment. And then from that treatment, I'm going to measure the effect. I'm going to walk a handful of times. I'm going to provide a certain amount of practice. And then I'm going to see, was I able to make an impact? Was I able to make a change in that walking deficit that I was looking to target? Now, it's still an important question, I think, how that change in those particular aspects of walking, are they going to translate to those standardized measures I'm using as outcome scores? And that's an area we need to look at a little bit separately. But hopefully you can see that use of these walking deficits can help us be a little bit more specific in our training. It helps us to inform our clinical reasoning. It helps us to evaluate the effects of our treatments. And then in terms of these robotic devices, it helps us to identify how those robotic devices fit into this whole process. Thank you very, very much.